I think then the talk is actually designed exactly for that group, predominantly for an outpatient management. So let's just get into this. I would focus predominantly on therapeutics because we don't know how Omicron performs against the vaccines in the Indian scenario yet, predominantly when we talk about Covaxin and Covishield much. So there is little information on vaccines, but mostly we will focus on the treatment aspect. Now, before we talk about anything regarding Omicron, we need to know how many proportion of our current COVID infections is caused by Omicron. It's quite clear that about more than 3/4 of our infections crossing towards the end of December to early January was being caused by Omicron in the metropolitan cities. And we expect that more than 90% would be Omicron now, not only in the cities, everywhere for that matter. So whatever Omicron holds true for therapy is going to be of enormous significance in treating these patients, because whatever you see as COVID now is likely to be Omicron. Now, to understand this, there are a few things that needs to be borne in mind. One is that if you take any population, this is data from Melur, but it is true across the country as well. 70 to 80% of people have evidence of immunity against SARS-CoV-2. So we are talking about a population, approximately only 30% that is vulnerable, naive to COVID. We all agree that the immunity against COVID might wane, be it vaccine related or primary infection related. But there is only a small proportion that is completely susceptible. Now, we also show the replacement capacity of various variants. If you look at it, from the days of emergence in South Africa, the way how beta and delta sort of dominated the variants, dominated the proportion of infections. For Omicron, that has been very, very fast. So in any given community, when Omicron is introduced, within a month or so, it has the capacity to completely replace the other variants by itself. Very rapidly, it can do that. That is something to remember. Now, all of us know that the death rate in India for COVID-19 has not changed dramatically because of Omicron variant. So there are no sudden increase or signals of a worse outcome in Omicron. That is predominantly because Omicron is more like a milder disease. Well, it can produce severe symptoms. It can produce high-grade fever, severe myalgia, and it can make somebody lie on a bed for a few days. But what we are talking about is oxygen dependency, significant lung involvement, and ventilator involvement. All those are remarkably lesser among patients with Omicron. This is early data from South Africa, but we all know that this is the pattern we are seeing in India also now. Now, if you look at the treatment of any COVID per se, you can conceptually look at it in 3 stages. One is the early infection stage. The second one is probably you can call the pulmonary phase. Then the third, this thing is where the inflammatory cascade takes over and produces more damage. So though all patients might not fit in typically well into this timeline, what this timeline probably does is gives us an easier framework to sort of understand how to treat these patients. So if you take somebody in stage 1, typically in the first 4 to 5 days of illness, they usually have mild constitutional symptoms, fever and dry cough. The bloods might show a lymphopenia. The focus in this group of patients is to prevent them from moving into one of these stages. So if there is any therapy that might work, be it an antiviral like remdesivir, molnupiravir, or even like an anti-inflammatory agent like nasal steroid, anything might be considered at this stage. Now, the second stage is a mix of both the viral replication as well as the host inflammatory response. This is the stage when patient starts to become sicker. So here we have good number of drugs already meticulously studied in randomized controlled trials that are available. So definitely remdesivir appears to have a role. Dexamethasone appears to have a role. Now baricitinib might have a role. And in severely hypoxic patient, even tocilizumab has a role. And prophylactic anticoagulation might be of help. And in the third stage is the hyperinflammatory response, when our focus should be to cut down the inflammatory response. In that situation, steroids, tocilizumab, baricitinib seems to have a role. So this is the overall way how a patient with COVID-19 presents. Now, one of the molecules that have gained a lot of promise during the second wave in India, which was predominantly driven by Delta variant, is the monoclonal antibodies. Now, you know, these monoclonal antibodies target the spike protein. They are directed against the spike protein of the virus, causing neutralization. So they are one set of agents that were completely much used during the second wave of the pandemic. Now here, if you look at the overall treatment, whatever is available, you have some monoclonal antibodies. Don't look at that name there. We will come to that why the regular one, what we use is not there. But the antivirals, what we have established efficacy is molnupiravir. There is a drug called nirmatrelvir ritonavir. You might have heard of that. It's not available in India yet. And remdesivir. Immunomodulators, you have corticosteroids, you have IL-6 inhibitors like tocilizumab, JAK inhibitors like baricitinib. And anybody who gets admitted into a hospital setting appears to benefit from a prophylactic anticoagulation. If you increase the anticoagulation unnecessarily, it appears to be associated with more bleeding. Now, let me just stay with you regarding this figure. Of course, sorry to put a complicated figure here, but what you see in those blue lines are Delta variants. Now, that red line is Omicron. Now, the molecules are given there. What we commonly use is casirivimab and indevimab. What is shown very clearly here is that, it has absolutely no activity against Omicron. If the graph climbs up like that, that means there is significant neutralization. So if you take this Regeneron combination that is currently available in the Indian setting, it has close to 0% activity against Omicron. So that's something very important to bear in mind. First of all, you're dealing with a mild illness. The chance of progression is very low. Secondly, you're also dealing with a variant which has a very heavily mutated spike protein. So your casirivimab plus indevimab combination barely has any activity. So monoclonal antibodies practically have no role in the management of COVID-19 caused by Omicron variant. Now, there are these other interesting monoclonals that are not yet approved in the country, which may have some good activity. What I have highlighted there for you is sotorovimab. Look at the way how the graphs are aligned. You would see that the activity against Delta, which is in blue, and activity against Omicron is very parallel when sotorovimab is shown. So probably a molecule like that would be of interest if it is available. But overall, currently available monoclonals have no role absolutely against patients with Omicron variant COVID-19 disease. Now, when we talk about antivirals, these are interesting molecules because they destroy the virus. any antiviral, if you look at the story from flu, you have to use it early. So you have to early use remdesivir or molnupiravir. These two are the current ones that are available. The trouble with remdesivir is that it's an IV preparation, and molnupiravir is a oral tablet. So now we will look at some of the evidences that is recently available, how very likely they retain their activity against Omicron also. So if you look at it, this is for patients who had less than 7 days of symptoms, to look at whether giving remdesivir as IV in an outpatient basis can help them to avoid hospital admission or death. So if you look at that image I have shown you in the right-hand side, you would see that the remdesivir group had significantly lesser rates of hospitalization or deaths. Of course, it's going to be a little tricky to give remdesivir with isolation precautions and all in a OPD setting, but the other option is to admit them and give it, especially if they have any high risk factors for progression disease, as high risk comorbidities, underlying lung issues, and things like that. So this is something you could consider in high risk patients with mild to moderate COVID-19. Now, this is another interesting molecule which have caused a lot of excitement. So one of the things to remember is that the full data on molnupiravir efficacy is not available to the world yet. What we have is a interim analysis of the Move Out trial, which is called looking at this tablet among non-hospitalized patients with COVID-19. Their outcome was also very similar to what I showed you in the remdesivir trial. It is hospitalization and death. Now, it shows as if the molnupiravir arm had decreased incidence of hospitalization and death. One of the things is appears to be some safety concerns with this molecule. It's definitely, there seems to be concerns about teratogenicity, and appears that it cannot be used in children. It might produce neutropenia. And also there seems to be some ligament and muscle damage as well. So it is a molecule to consider in patients with high risk factors, but there are some side effects to remember. So that's about molnupiravir. Now, this is one of the subgroup analysis regarding molnupiravir. If you look at it, they have checked in various subgroups how the benefit of the drug was distributed. So what you can see is the benefit is all over the place. Usually, if a drug really works well, you will see a sustained benefit across various subgroups. That's not what we are seeing with molnupiravir. Now, this is another agent which is not available in the country yet, but it was studied in a much larger population. And there was a dramatic difference in the hospitalization and death by day 28. The effect of the impact by the molecule was much more stronger than molnupiravir. But currently, unfortunately, it's not available in the Indian setting, but will be available shortly. Now, if you look at the subgroup analysis for this compound, nirmatrelvir, you would see that what I was trying to tell you, that all the subgroups showing a similar trend is very clearly seen with this molecule. This is what we see in a very impressive performing drug. So this is a drug to watch out, and it's a very important molecule we should anticipate. Now, what are all the strategies? So since there are going to be a lot of mild patients, we should have a very good admission criteria, who we should admit, who are potentially going to require oxygen bed or even NIV or ventilation, and a careful assessment of disease severity and risk factor, duration of illness, and planned treatment. Now, this is a summary of treatments we use. It's a very simple summary. I will just run through that. If somebody has mild disease, usually they are very acute, fever, cough, sore throat. And if they have lot of, we barely give them any medicines, regardless of comorbidities also. Usually we just give them symptomatic therapy. We might use inhaled budesonide, 800 microgram twice a day for people with persisting symptoms for more than 3 days. And they can be safely isolated at home. Here, the disease is predominantly driven by viral replication. On people who have moderate disease or people with very significant high risk factors, especially with persistent symptoms lasting more than 5 days. There is no hypoxia or anything here, but chest X-ray might show an infiltrate. They may have an elevated CRP. We might choose to admit them. In those patients, we use remdesivir early, continue budesonide, and low molecular weight heparin in prophylactic doses, and monoclonal antibodies, molnupiravir in select patients. We don't use monoclonal antibodies during the Omicron variant because it doesn't have activity against it. Now, severe and critical guys are the people we are worried about. Usually they present later, may not be so always, but mostly they have evidence of serious involvement of the lungs and also other multi-system involvement. There is a gross involvement in the radiology with elevated inflammatory markers. So here, the approach seems to be cutting down the inflammation. So you add steroids, baricitinib, maybe plus or minus remdesivir. The role is not very clear. And enoxaparin, tocilizumab, if there is clear worsening and CRP more than 75. So that's something to think about in COVID-19. This is our model, but you could have variations in your setting as well. Now, vaccines, I've just put only one picture. I would just run you through that picture. So if you look at all these bar diagrams, the first two diagrams shows people who have received 2 doses of Pfizer vaccine and AstraZeneca vaccine. AstraZeneca vaccine would be our Covishield. Now, M5 means that they have received it 5 months ago. Now, for Delta variant, that is about 81% protection, but Omicron, after 2 doses, 5 months down, there is barely any protection against Omicron. Similar story for AstraZeneca vaccine also. There is increasing evidence of boosting. So let's say they receive a 3rd dose of the vaccine. 1 month later, there is almost 100% protection with Pfizer vaccine against Omicron as well. Similar data with very good protection against using AstraZeneca also is emerging. Now, these are convalescents. Convalescents meaning that they have had the infection before. If they had the infection 6 months ago, look at the Omicron, only 36% are protected. And if the infection was 12 months ago, only 33% are protected. If they had infection 12 months ago and 1 month ago, they had only 1 booster with the Pfizer vaccine, they have 100% neutralizing titers against Omicron. So what is the essential moral of it? It shows us that when time goes, our vaccine protection also drops a bit, especially after 5 to 6 months. So one might need a booster. And most vaccines appear to retain some efficacy against Omicron. So it is important to boost and keep the immune memory up to date. This is my last slide. So currently, Omicron is the dominant variant. It produces mostly mild disease. No role for monoclonal antibodies. Very minimal role for molnupiravir and remdesivir. Boosting of vaccine response is essential, especially if the previous doses were many months ago. Thank you so much.
Dr. Abi Manesh, you said Pfizer vaccine is almost with the booster dose 100%. So what about the vaccines we receive, Covishield or Covaxin? And what is your experience on this?
Yeah. So maybe if you look at vaccines for COVID per se, the vaccines are directed against protecting against hospitalization and death. That is the main role for vaccines. Even when we came up with, started using it, we knew that infection will not be prevented. Now, mild infections will invariably happen regardless of how many boosters taken. That is not something a vaccine might be able to ever completely protect. So what we are looking for is definitely vaccines will work even against Omicron for hospitalization and death, that small proportion also. But the infection risk might not be completely eliminated, even for a variant, right, which might come in future also. So that might not be the case. So we may have to take boosters. Unfortunately, that appears to be the data that is coming out of countries like Israel. But looks like definitely serious disease, hospitalization, death, and all will disappear with vaccine dramatically. That's what it looks like.
Azithromycin is being used rampantly in mild cases, and some doctors claim that it has antiviral properties. So, what is your opinion on azithromycin?
Azithromycin was a very interesting molecule initially because it has some anti-inflammatory capacity also. So azithromycin has been studied in two large trials. One is based at Brazil, I think. The other one is the recovery platform by UK. Both has clearly shown that azithromycin has absolutely no role in any of the clinically important outcomes when given for COVID-19. So that is the reason why azithromycin has been withdrawn from most of the treatment guidelines. So that is why people don't suggest to use it. There might be a role if a bacterial this thing is suspected, but definitely not for patients with COVID-19.
So, steroids are widely used in treatment of COVID in hospitalized patients in various combinations. So, what is your insight on that?
The role of steroids typically starts when there is organ-threatening inflammation in the lung, which we clinically pick up by hypoxia. So if somebody is hypoxic, definitely they need IV or oral steroids. In the rest of the population, you could use inhaled steroids, nebulized steroids. The nebulized steroids dose is 800 micrograms of budesonide, which is used for 10 to 14 days or till the symptoms subside. That is one, in mild patients. In patients who are hypoxic, it is 6 milligram equivalent of dexamethasone for at least 10 days is the dose that is suggested. It can protect even from death is what the data shows. So routinely, there is no need for an antibacterial coverage in COVID-19. So definitely antibiotics are not indicated. No need for vitamins, supplements, and things like that also. What one needs to go for is look at whether they need an antiviral or not. That is the most important question to answer. And decide on that and inhale steroids if needed. That's all is required. Yeah.
Budesonide's role in mild cases with mild respiratory symptoms. So, should that be used or what?
Yes. So the thing is, if somebody has a mild COVID-19 and has a significant cough, suggesting that there is a respiratory involvement, then definitely budesonide has a role. And the dose I mentioned, 800 microgram BD, it's a higher dose than what we use routinely for things like asthma. So definitely it could be used up to 10 to 14 days or till symptoms disappear. What's the role for productive cough in COVID-19? See, what you see is a tracheobronchitis, if at all, what results in that productive cough. Multiple times it has been shown that antibiotics don't help it. What really helps is steroid inhalation. So if you use budesonide in that population, it really tends to settle down the symptoms because essentially it's an inflammatory response in the airways that is mediating that cough.
So is it good to start with oral steroids while the patients are at home isolation?
Yeah. So recently when the second wave of COVID-19, we had more than 300 patients with mucormycosis admitted in our hospital, COVID-associated mucormycosis. So when we analyzed that, the number one risk factor why they developed that was indiscriminate steroid use. So oral steroids at home is a really dangerous option. So if your patient is a diabetic, uncontrolled, it can really tip them off to at risk for mucormycosis. Wouldn't suggest that. So I think better to go with a high dose nebulization, nebulized, with the meter dose inhalers of budesonide, which would be much more safer.
There is an increase in dimer and CRP and troponin level dose. If it is a problem, why people are getting post-COVID cardiac problem?
So this post-COVID cardiac problem, we need to look at it in two aspects. One is that like flu, influenza, COVID puts you at a slightly higher risk of myocardial infarctions. That is one. The second thing is something called a multi-system inflammatory syndrome, like in children. Adults also can develop it with some cardiac involvement. Those are the ones that are described. But one thing I want to just tell you is that just elevated D-dimer, just elevated CRP doesn't mean much unless your patient is doing worse. If they are doing stable, if they are recovering, don't worry about the test. Follow them up more clinically, repeat them as needed. What you would invariably realize is that there's a lot of inflammation in COVID, but then that usually settles down, and better to base your treatment decisions at the bedside. If you're seeing hypoxia and things like that, and then react is probably better. Yeah.
So what's your take on gabapentin 100 mg for cough in patients with COVID or even with people with chronic cough?
I have no idea. So I have not used gabapentin in this situation. One of the molecules that has something related to neurological medicines that was studied in an RCT is fluoxamine. Fluoxamine tended to reduce hospitalization in COVID-19, but it looked like more to do with the anxiolytic property of the drug rather than to anything to do with the antiviral property. Gabapentin, I have no idea. I have not used it. Mucinex is more of symptomatic therapy. You could use it as long as the symptoms settle. So like how you would use Benadryl, Corex or something like that, you could go ahead and use that. Yes.
It was a very nice session. Sir, Dr. Abi Manesh has given answers to all of the questions. There were a lot of questions, and maybe people have a lot of queries because all these people or all the clinicians who are treating the patients. See, this is something new. What we are seeing every time. The first wave, second wave, basically Corona or COVID itself was something new for everybody. So and every time we were saying some new criteria, some new cases, some new treatment was coming every day. So it was very difficult for all the clinicians to treat the patient and for the decision making. So I think most of them now have got a good view about the treatment, and Dr. Abi Manesh has given a very good talk, and he has explained the situations, the use of vaccines also, the efficiency of vaccines also. He has explained in a very correct way. So it was a very nice and informative session. So let me thank Dr. Abi Manesh for his useful session, and I am very thankful for all the participants, those who have actively participated and interacted with our speakers. I am also thankful for the organizers, and I am also thankful for the Meenakshi Lab management for organizing this webinar and giving knowledgeable sessions for all our attenders. So thank you all.